Welcome back to RootCanal360. Today we're going to be working on tooth number 30. The diagnosis for this tooth was pulpal necrosis with symptomatic apical periodontitis. You'll notice we have the rubber dam placed. We have caulking surrounding the margins of the dam and tooth. We're going to first access through the porcelain. This is a PFM crown. That's a porcelain fused to metal crown. It has porcelain as the structure that is visible and the metal substructure underneath. You're going to notice the first burr I used was a diamond coated burr. Now I'm using what's called, in short, the L35. Let me introduce you to this burr. It is one of my favorites. This little burr, its technical name is the H35L Friction Grip 012 L35. At first, that name looks like a jumble of numbers and letters, but each part of that name tells you something important about that burr. The 35 is the key. It tells you this is a cross-cut tapered fissure burr. Those little crosscuts on the blades act like serrations on a saw. They keep the debris from clogging the flutes and make the burr far more efficient at cutting through tough material like metal in a porcelain fused to metal crown. That's why this is such a reliable choice when you're sectioning or even removing crowns or accesses for endodontics. Now the L means long. This is kind of an extended head version. The working length or the cutting flutes is about 3.7 millimeters, which gives you the reach to section the entire crown in one continuous motion. It also makes it great for accessing for endodontics because that length allows you a deep penetration into that tooth and cutting all along that without undercutting it too much, losing your visualization. Now the FG. The FG stands for friction grip. This burr is built for your high speed and not a latch. The 012 gives you the diameter of the head, which means that the diameter, the cutting area, it's 1.2 millimeters. That's kind of a sweet spot in my opinion because it's small enough to control, but wide enough to cut quickly. You can appreciate this more as you use it. The balance the first time you use it is amazing and it zips through any sort of material. Full coverage restorations that are all metal, PFMs, or if you've got to do what I'm doing here, you've got to section that crown. Now, when we made this access, the caries was extensive underneath the crown. So we decided to section this crown and remove it. I'm using this L35 to do that. Now, as you'll notice, there's a little black line there. There's something that everybody should know. That black indicator line from the shank is important. From the tip of the cutting head to that line, you're looking at 6.7 millimeters. Now, if you remember right, the distance between the fossa and perforating a tooth is about 8 millimeters on average. So if you've got that black indicator line and you're using it for an endodontic access, that'll tell you that you're about 6.7 millimeters deep, and if you push it too much deeper, you may perforate that tooth. That is awesome, especially when you want to do a quick but precise access. Now, technique matters here when you're using this burr. You want to make sure you have lots of coolant, but you want to keep the pressure light. Let the burr do all of the work for you. If you push it too hard, you'll generate a lot of heat, and you're going to really dull that blade and shorten the life of the burr. If you let the design do its job, it'll cut really smoothly and really efficiently. Now, it's purpose-built for crown removal. I use it for accesses because we go through a whole lot of crowns. If you learn to use that burr, you're going to save a lot of time. You're going to save on a lot of different types of burrs. And you're going to make the whole process easier on you and on patients. So remember the H35L FG012L35. It's going to be a lifesaver for you. Now back to the video really quick. You'll notice we just removed the dam. I've got one more area of that crown to remove. I'm going to still use that L35 burr to remove the porcelain and the metal from the mesial aspect of that tooth. I'm going to use a very light, gentle stroke, making sure I do not touch the distal aspect of tooth number 29. I don't want to create a divot. Sometimes it happens when you apply too much pressure, but you want to make sure that you're always doing a gentle stroke and stay away from that mesial aspect. It'll make your life a whole lot better, and it'll make things better for your patient as well. Now what I'm trying to do here is spread that crown out. I haven't removed enough metal, so it's real stiff. You'll notice the porcelain fractured. We're going to get rid of that porcelain. I'm telling my assistant where it's at. She's going to suction it there for me. We're going to remove more of the metal and porcelain. Always making sure that your suction is there, because the last thing you want to do is have a piece of porcelain or metal shoot down your patient's mouth. That's not very pleasant. I'm going to gently remove that metal, always sectioning in a controlled manner. It's really easy when you're cutting through metal to have the burr slip, and it'll always slip where you don't want it to go. In this case, it's going to slip going to the mesial or going to hit the distal aspect of tooth number 29. Now this is an older patient. He's had this crown on for a long time. He can't remember exactly how long, but more than 10 years. Now you're going to notice that porcelain kind of chips off, and I really want to make sure that that suction is there at all times. As we gently remove more and more, this is going to be really easy. Now the instrument that I'm using here is just the glick. There are crown separators. The glick is often a very useful tool in this. You don't necessarily need to have the crown separators. I use a glick on every case. I like to keep my instruments very minimal. In some cases I have to use a crown spreader, but in this case, again, I'm just using the glick. It does the job very nicely. And now we're done with that aspect. What we're going to do now is put that dental dam back on. We're getting it ready. I'm getting the clamp all situated to go back on that tooth. Now I'm going to put the rubber dam on slightly different this time. I'm going to secure it below the area that I know the caries exists. I always like to put the clamp on first and then extend it, even though they've got the wings on it. I find it really easy. I use the easy dam, and then I use a piece of floss to push that dam right through that contact on tooth number 20, in between 29 and 28. It's not always easy, but in this case it went really nicely. The next aspect is always to place our caulking agent. I want to make sure that we keep any sort of moisture down from getting into the patient's mouth or having our contaminants tasted by the patient. The handy dam here is really nice, but one of the things it does is it kind of folds a little bit. So you'll notice I undid the adhesive on the edge just to give it a little bit more flex. I like to take a wet cotton pellet. I'm going to smooth my caulking agent down, get it looking very clean, manageable. I don't like getting caulking on my gloves. It's kind of annoying. Now it's time to remove the caries. You'll notice I'm using the L35 again here to remove all caries. Dental decay or dental caries underneath that crown was very extensive. As we get in there and remove the caries, you're going to see that open up very nicely. This will be one of the easier cases to visualize what's going on. Can we take just a few minutes to talk about what everybody knows of and has heard of, but lots of people don't really understand it? And that's dental caries. To most people, that's known as a cavity. Now, most people know now that cavities aren't holes that suddenly appear overnight because you forgot to brush once or twice. The scientific consensus, as Pitts and others have put it, is that dental caries is simply a biofilm, a collection of bacteria that is mediated, sugar-driven, multifactorial, dynamic disease. In plain English, it's a bunch of bacteria that live in a plaque, eat sugar, produce an acid, and slowly tip the balance toward demineralization, or they eat your tooth away with acid. The chalky white spot that appears on a tooth, that's an early sign of the battle. The hole that lots of people talk about or see, that's when the tooth has lost its ground. Think of your tooth like a house. The enamel is the roof, the dentin, the walls, and deep inside is the living room, the pulp. It's full of nerves and blood vessels. As long as the roof leak is small, you can patch it with a filling. But if the damage keeps progressing and water floods the living room, the pulp gets inflamed or infected. At that stage, no patch job will save it. You need either pulp therapy, if you're younger and the chamber's huge, or full root canal to clean out and preserve the tooth. Traditionally, dentists used an explorer, the sharp metal stick, to feel for a sticky spot. But today, most leading experts and groups say the use of a sharp explorer is not necessary and sometimes not even good. Instead, we rely on visualization, drying the tooth, good lighting, magnification, a ball and probe just to gently check surface texture. And it's really important to see that difference in that texture. It's experience will teach you that. Radiographs, they help for those sneaky spots between the teeth, the flossing cavities or interproximal. There are new tools like light-based scanners. They're great for visualization without poking holes where none existed. Once we find the caries, we remove it. The modern mantra, less is more. We don't chase every stain and groove. We aim to remove the soft, mushy dentin that harbors bacteria while leaving behind the firm dentin that the tooth can live with. This is selective caries removal, and it dramatically reduces the chance of hitting the pulp, but in our case, we don't really care. Cavities are like Netflix series. If you catch them early, you can stop, but you can stop after season 1, but ignore them, and suddenly you've 10 seasons deep with no way out. And now you need a root canal. So whether you're a student just starting or a patient curious about why your dentist is staring at your tooth under bright lights without poking every spot, it's because modern dentistry is about preservation, visualization, and minimal invasive care. The goal isn't just to fix holes, it's keeping your tooth alive and functional and happy for a long run. Dental caries, however, took this tooth and it needed a root canal. As you could tell, after removing the caries, there's a sufficient amount of tooth structure left, but not a ton. We've identified the canals, and now I'm enlarging the orifice of the canals with my ultrasonic. On the mesial roots, there's always a fissure in between the canals. Oftentimes there will be a hidden middle mesial canal, so I will often trough in between those two canals, the mesial buccal and the mesial lingual canal. When you trough, you have to be very careful not to go too mesial or too lingual. You don't want to perf out the mesial aspect of the root, nor do you want to perforate into the furcation. Now, you'll notice here I've taken some cord and I've soaked it in a material that helps dry any sort of bleeding. Eventually I'm going to be placing a core restoration, and I want this to be nice and dry. I'm going to place this cord into the sulcus. It's going to create clotting and stop the bleeding. We don't have a ton of bleeding, but I don't really want any moisture around my margins. Anything that's going to compromise my seals is what we want to prepare for. After that's placed, I'm going to go back to the endodontic process. I'm going to use the ultrasonic to open up the orifice of those canals. When we talk about opening the orifice in endodontics, the traditional tools we reach for historically were the Gates-Glidden drills. In fact, if you ever watch Finding Nemo, you'll see that there's that part, and it says, he's favoring the Gates-Glidden lately. The Gates-Glidden is great for opening it up, but it gives it a perfect round Coke bottle appearance. There's also other files that are specifically made to be orifice openers. These are all fast, and they've been used for decades, but there's an issue. They cut in a perfectly round, concentric fashion. The canal anatomy, it's not perfectly round. In fact, it's more oval and irregular and full of nuances. So when we put a round file into an oval canal, we end up cutting away a lot of dentin that we didn't really need to remove, especially in those danger zones near the furcation. That's where strip perforations and unnecessary weakening of the tooth come into play. Now, let's compare that to the ultrasonic unit, which I prefer. With the ultrasonic, I'm not locked into the geometry of a spinning drill. Instead, I have a fine, vibrating tip that I can move exactly where I need it. Brushing away the dentin selectively under magnification, I can literally sculpt the access and flare the orifice in a way that respects the natural anatomy of the canal system. It's not about making a beautiful round hole. It's about making it correct. The ultrasonic gives me the ability to be conservative and aggressive all at the same time. I can preserve cervical dentin, which is the structural neck of the tooth and critical for the long-term survival. At the same time, I'm creating a true straight line access to the canal. And let's never forget the added benefit. As I'm refining the orifice, I'm also vibrating and cleaning debris away, something the Gates-Gliddens or other rotating files are not so great at. So files and drills are fast, but they're blunt instruments. Ultrasonics are precise. They allow us to open up the orifice in an anatomically correct way rather than a geometrically convenient way. That means stronger teeth, fewer errors, better long-term outcome. And that's why when given the choice, I'll reach for my ultrasonic every time. You can see that I've actually opened that up a fair amount on the mesial, looking for that middle mesial canal. Sometimes that canal just doesn't ever really open up, and it's more of a fissure that you can see, that nice staining. Those cases always drive me crazy because I know there's going to be bacteria hiding in those little tiny spaces that I can never quite get to. In this case, we're applying a little more sodium hypochlorite. I never use any sort of gel for lubrication. It disrupts my visualization. I prefer to use sodium hypochlorite while I am cleaning and shaping. Almost immediately you can see the effervescence. That's usually an indication that the sodium hypochlorite is incredibly active. I'm going to use a little more ultrasonics to help clean away any sort of debris that I've just created. And I'm going to give it a nice rinse. I'm going to suction it and dry it. Visually, I'm starting to notice that those two canals actually end up coming together. And it's starting to curve towards the furcation. So I've decided no longer will I try to use my ultrasonic tip to open that up any further. I've decided now at this point we're going to measure those canals. Now, as you've heard me before, you want to make sure that the file that you're using has a snug fit and is touching as much of the canal wall as possible. It will increase your accuracy. Apex locators are incredibly accurate. As you get that length, I'm going to make sure I create a nice little stop on a reproducible area. I'm going to measure it. I'm going to have my assistant, of course, write that measurement down. They're going to record it in our chart notes. So if I ever have to re-access this tooth for any reason, I know exactly how long it is. But I've also predetermined using my CBCT the measurements. Now, sometimes because of metal or other sort of distortions, they're not exactly spot on, but they're fairly accurate. There's about a 1-to-1 ratio with a CBCT and about a 99% accuracy with the Apex locator. So both are incredible, but I use the CBCT to give me a general idea of the length, and then I use my Apex locator to determine the precise length. Once I get that precise length, I'm going to flood the chambers with sodium hypochlorite. Sodium hypochlorite, of course, is the medicament that we use. It's bleach, in essence, straight from a bottle. Never using any sort of thickening agent in it, nor do we want to have any sort of scent in our sodium hypochlorite. We want straight out of the bottle, old-fashioned bleach. We could talk about diluting the sodium hypochlorite. I use it at full strength. There are many people that prefer to dilute it because of the dangerous nature of sodium hypochlorite if it touches healthy tissue out the apex. I prefer to always just make sure that we irrigate carefully. I like sodium hypochlorite in its full strength because the reason I'm using it is to kill bacteria, viruses, molds, yeasts, funguses, whatever's inside that tooth. We want to make sure that we disinfect it as best we can. Always gentle. I bend my irrigating tip to 2 millimeters short of my working length. As you irrigate, many studies are out there that show that your irrigation will actually push about 2 millimeters past the exit in the tip needle. And so you want to make sure that you stay beyond that, but you don't want to stay far beyond that because you're not getting the sodium hypochlorite down the canal like you need to. As we open this tooth up, I use a modified crown down method. In my last video, I talked extensively about the modified crown down technique and how it compared and differed from the traditional crown down technique. Don't necessarily want to talk about that too much today, but what's beautiful is that we can see very clearly what's going on in those canals. Now, as we suction spit, one of the hardest things to deal with as a microscope is the constant movement by patients. Sometimes it feels like I'm at sea because it's so zoomed in. I always keep mentioning the microscope, but it's one of the biggest game changers in modern dentistry, or especially in endodontics. I use the global 6-step microscope. The name comes from the 6 preset magnifications. At the lowest setting, you're looking at the whole tooth and surrounding field. At the highest, which is nearly 20 times magnification, you're examining details smaller than the width of a human hair. That means hidden canals, tiny cracks, and subtle decay that would be invisible otherwise suddenly become incredibly clear. I wish that my camera showed that as well. As I'm saying, I definitely need to get a better camera. I'm using currently the global 1080 camera, and it has good visualization, but the light isn't perfect, and it doesn't quite match up with what I see when I'm working. However, it's good. Now, magnification is what makes dentistry easy, but it's only half of the story. The global scope has a fiber optic lighting. It's a coaxial fiber optic light, which is just kind of a fancy way of saying the light shines exactly where I'm looking. Now, there's no shadows, no guesswork. It's looking into a cave with a flashlight from the side versus looking into a cage with it perfectly on your eyes. That's what the microscope does. I just wish you could see it as good in the camera as I can see it in my microscope viewing lens. If you're a new student and you use a microscope for the first time, this tool, the microscope, changes everything. Instead of hunting for any sort of anatomy, hoping that you're right or in the right place, you actually see what's there. It's like switching from black and white sketch to a full high definition image. And if you're a dentist and you've been practicing for years, it's not just about what we see, but it's also about how we work. You know that sitting there for long hours bent over is exhausting, and anybody who does manual labor will think that's such a joke. But to hold that static position is a lot harder in the long run, day after day, than you would initially think. With this microscope, you get to sit up almost straight up, nice and upright, relaxed, and you let the optics do the bending. That saves your back and your neck over a lifetime of practice without having something heavy sitting on your nose. For many years, I was a general dentist, and I remember sometimes how much the loops would weigh down on my nose after a very long procedure. Endodontics are longer procedures, and the microscope is a game changer. Now, the global microscope, it's fantastic. It's made in the US. It's durable. It's simple. It's smooth controls. I like it better than the higher priced European brands because you get simplicity without sacrificing clarity in the image. Now, you'll notice here that we've done the cleaning and shaping, and I'm trying the cones in. Now, I try my cones in with EDTA. I rinse out all of the sodium hypochlorite, and I try the cones in with the EDTA just for safety. I don't want to push any sodium hypochlorite out the apical exit into the tissue and cause massive destruction with that. So instead, I place EDTA, try the cones in, make sure that they fit. Every time I put a cone in, I make sure I get a little bit of a tug back. That way I know it seats beautifully and I'm not going to pull back on it when I burn off the excess. It's one of those clinical tips that you don't realize is important until you pull out your first cone, burning off the excess. And then you will be frustrated and you're going to realize, yes, I need a slight tug back. Now that I've got all the cones fitted, I'm going to do a final rinse with sodium hypochlorite. This rinse will take for what feels like ever. There were and there are times when the cones don't fit exactly the way you want. And so to refine the canal, you'll actually have to sometimes go back in with the file to make sure that any sort of debris or the path that the cone is supposed to take is clear and unobstructed and you get to the length that you want. Now I use a very large syringe full of sodium hypochlorite and we're speeding up the process to ensure that I don't lose too many of you while I irrigate this tooth. Once we're done with the irrigating, it's important that we dry the canal before we place our sealer. How we handle that step directly affects whether our sealer does its job properly and whether the root canal stays sealed for a long time. By the time we reach this stage, we've already done a lot of work. We've irrigated thoroughly with sodium hypochlorite to dissolve the organic tissue and to disinfect. We've followed up with EDTA to remove the smear layer and expose the dentinal tubules. Those are critical steps, but now right before obturating we need to shift gears, think about the environment we're about to introduce our sealer into. You'll notice I've placed paper points. With bioceramic sealers, the science is clear. They're hydraulic material. That means they actually require the presence of moisture. So when I dry these out, I don't desiccate them. I don't create a desert. But I also don't want pools of sodium hypochlorite or EDTA. So what's the balance? Research consistently shows the best environment is a slight moist canal, not wet and not too dry. To achieve this, after the final irrigation, we remove the excess irrigant with either a microsuction or I pull back on the syringe to pull some of it out. Then follow up with the paper points. Then we can allow the sealer to come in. You're going to notice the sealer is going to push up through both sides of the canals in that mesial root. And I'm getting much of that sealer in the isthmus in between the mesial buccal and the mesial lingual canals. Why does this matter? Because in this condition, the bioceramic is able to flow beautifully into those microscopic spaces, penetrating the tubules and hydrates fully. It needs some of that moisture. The result is dimensional stability and an intimate seal along the canal walls. I'm going to burn down the excess gutta percha. I'm going to press and create a nice even flow. I don't really care if the gutta percha touches much of the walls, but I also don't want gaping holes. The most important part of any sort of obturation is actually the sealer. We know we have now a nice fill, three-dimensional fill with the bioceramic sealer. We're just going to burn off any of this excess gutta percha. I'm going to place the final cone, which is a 3504. You'll notice the green stripe. We're going to place that in. The two canals merge at the apex. Now once I burn this off, this is a single cone technique. I could fill that rest of that chamber up with composite restorations. I like to top off any of it with gutta percha. I like to make sure that I have a little top of gutta percha over my single fill just in case there's voids, because I'm going to irrigate with water afterwards and I don't want to wash away any of my bioceramic sealers. So I'm going to place a little more gutta percha, warm gutta percha, and then I'm going to compact it into a nice, tight seal on top of the single cone. Again, the only reason I do this is so that I don't wash out any of the bioceramic sealers that are so important to sealing up those canals. Any excess sealer that's filling up those voids that the gutta percha doesn't, I want it left intact, and that's the only reason we place a small cap of gutta percha on top of it. Again, it's not a true backfill. I'm not burning down the gutta percha so that I have to backfill the chamber with warm gutta percha. I'm just doing a single cone, and then I'm placing a small cap of gutta percha over it to make sure that any sealer remains if there's a void between the gutta percha and the walls of the canal. Once this is done, I'm going to place a little bit more step by step, making sure that it's a nice, good, tight seal. Not pushing too hard, but nice and firm. Oftentimes this feels like wet sand. It kind of, once you press it, it moves very readily and sometimes could be frustrating the first couple times you do it. You don't necessarily push, you just kind of tap it down into place with gentle pressure. Once you get that gutta percha into a nice, tight, intimate feel with the canal walls, it's time to remove the excess sealer, and you're going to rinse and irrigate it really well. I do not want to leave any sort of sodium hypochlorite or EDTA on the outside of that. And officially, this is where our root canal is done. The patient was fantastic. They tolerated the procedure well. At this point, I'm going to get ready to place the core. You're not here to watch the placement of a core restoration, but I'm going to video it anyways. I'm going to talk through it just a little bit, but I'm going to speed through it fairly quickly. I'm going to put this on 2x speed. You're going to see me place the core. There's a few things you're going to notice that might shock you if you see it for the first time, but I'm not necessarily going to place a matrix band around this tooth. I'm not a huge fan of placing matrix bands, not because they're bad or they're not good at their job, but I find them kind of annoying. I don't need a nice tight contact. In fact, I want an open contact so that the patient is constantly reminded that they need to go get a crown after we're done. So we're going to place that core on top of this root canal, and we're going to speed through this fairly quickly. We're going to first make sure that everything's good and dry. I'm going to place an etch over the exposed dentin. We're going to let that sit. Then we're going to give it a thorough rinse for at least 30 seconds, making sure that we remove all of the residual material. We're going to have this nice and dry, not desiccated, but also not wet. You're going to see a slight glisten. I want to make sure that on the mesial aspect there's no moisture. We're going to place a bonding agent, a universal bond on this tooth. Once we place that bond, we're then going to air dry it just a bit. Again, not desiccating. The science between after placing it and blowing air is important to know and understand. We want to make sure that we coat all aspects of that tooth. There we are again, applying air. We're going to set the material. We're now going to place our final core restoration. I don't use a matrix band on many of these cases. I do want to make sure everything's good and dry. I oftentimes blow air to make sure that it's pushing it against every aspect of that tooth. We're using a dual cure flowable core material. The shrinkage on these is not what it used to be. Packables shrink less, flowables shrink a little bit more, but thanks to the new materials that they have, very little shrinkage occurs with these flowables. We're going to light this up, then we're going to let it set for a little bit. The goal in this is to make sure that the patient has a solid seal that is also easily kept clean. I want to create a beautiful but functional tooth, something that's ready for my dentist to easily place the type of margin that they want. Removing that cord, I'm going to remove any sort of flash composite that exists. You're going to see just a little bit of bleeding now in that area. Trying very carefully to not remove any more tooth structure, just excess flash from the composite being placed. I want nice rounded areas, something that's not going to cut the patient's tongue. Nothing like having a patient come back saying the filling that you just did cuts against their tongue. So you want to make sure it's nice and rounded. I really like the football burr. A fine grit football burr is fantastic for this. Put in just a little bit of anatomy. Again, I'm not cutting it ready for the crown, but I do want to make it as close to ready as possible so that the dentist that gets this is incredibly happy, and it just takes them just a few minutes to put the final touches on it so that they have a nice margin that they like. I'm going to take the rubber dam off. Once that is off, I'm going to clean up the edges just a little bit more. Notice there's still some staining from the old crown. I'm going to remove that. I don't like the appearance. I also don't like the possible biofilm that exists there. So I'm going to take, of course, my favorite instrument that I use a ton of, which is the ultrasonic. And we're going to remove it. Again, this patient was fantastic. I believe it was his birthday the day he came in for the root canal. Quite a celebration for them. I'm going to get this corner here. That distal lingual is the most irritating corner to get for the patient. You'll notice some dark staining on the edge there, but other than that, that is a tooth ready to be crowned, and hopefully I'll never see that patient again. Thanks for your time.